Good evening to one and all. Sorry for the delay. I really don't know what went wrong. Anyway, so we had a good talk on mucositis and xerostomia. Now moving on to the panel discussion about both these topics. So to begin with, I'd like to welcome my panelists, Dr. Vipul Nautiyal, Dr. Dodal Mandal, Dr. Vikram Gota, and Dr. Sarbani Madam. So you all know head and neck cancers. I think you agree in India has distinct demographic profile, risk factors, food habits, and personal and family history. And they're emerging as major public health problems in India, which are lifestyle related, have a lengthy latent period, and need dedicated infrastructure. So with the extensive treatment comes the serious complications. You obviously have to bear that brunt. And almost 40% of our cases we see in our OPD are head and neck cancer treatment radiation related, and most of them are locally advanced. So RT causes, RT in the head and neck region causes both acute and long-term complication because of adverse effects. Now, late complications are chiefly the results of chronic injury to vasculature, salivary glands, mucosa, connective tissue, and the bone. So if you look at the first thing, that is xerostomia. Now I have a few questions to my panelists. I don't want to name any particular panelist. Anyone can take this. How do you define xerostomia? Do you have any particular definition for this? And how many cases of xerostomia you see in your day-to-day practice when you're treating patients? And what do you see the effects of? How do you see the effects of xerostomia in a patient?
So your question, it is the decrease in the salivary flow rate, and if I'm not mistaken, it is below 20 to 25 ml per minute.
That's right.
And, in the amount of the salivary flow rate, this is what we're talking about.
Yes.
And the incidence, if you ask me, yes, we do come across it. It's a frequent problem. It's not something that's uncommon. Neither is it rare. And I would say that we would see grade 3 xerostomia in practically about 60 to 70% of our patients.
Yes.
Essentially because I see a mix of patients treated with telecobalt conventional radiotherapy as well as IMRT. Of course, the rates would be lower in the long-term follow-up of patients who have been treated with IMRT. But patients who have been treated with conventional radiotherapy, the rates would be much higher, around 60 to 70%. And the effects of xerostomia, of course, are both directly related to the xerostomia and the consequential effects of xerostomia. And these, of course, encompass the per se, because of the saliva becoming more viscid, losing its inherent characteristics, having adequate electrolytes, the enzyme, as well as its the viscosity, and of course its antimicrobial properties. So you see that effect of xerostomia. So patients have to change their food habits, what they eat, how they eat, and when they eat. And of course, the consistency is one of the major issues that you see with xerostomia. And the consequential effects are on the entire oral mucosa as well as the dentition in the oral cavity. And of course, the propulsion of food, mastication, everything becomes a problem as a consequence of xerostomia that we see.
Yes. Can we go to the next slide? I'm unable to change from this. Yes. So as ma'am rightly said, it's defined as a dry mouth, reduced salivary flow. And ranges, I think we see in all these patients, grade 1, grade 2 is quite common, is what I have noticed also. And xerostomia has late effects on oral health, specifically dry mouth, sore throat, altered taste, dental decay, changes in voice quality, and impaired swallowing function leading to nutritional depletion and weight loss. Now, if Dr. Dodal Mandal is there, would he like to comment on the effect? Yes. So moving on to the most important thing when we treat the patients is salivary apparatus. You know, parotid and submandibular are most important structures. Submandibular is because of the in unstimulated state, submandibular gland produces the most of the saliva, that is the resting saliva, whereas in stimulated state, the parotid is responsible for the saliva produced. And the total salivary flow can be 1.5, almost 1.5 to 1.8 liter per day in healthy individuals. So I would like to ask Dr. Dodal if he's here, factors affecting the salivary gland function.
So I would like to give the answer of this question. What are the factors? Basically, multiple factors, multifactorial. Apart from the radiation doses, volume, how much what technique you are using for the radiation, and the patient nutritional status, and the oral hygiene. These are the various factors which affects basically the salivary gland functions.
So it is basically the dose volume correlation which we have. I think we are well versed with the doses when we are treating. We limit our parotid doses, the mean doses, to 26 gray. So it has been shown that the minimal gland function reduction occurs at 10 to 15 gray mean dose, and gland function reduction gradually increases as radiation doses escalate. and with the strong reduction, usually 75% at more than 40 gray mean doses. And Sarmani ma'am, would you like to comment on how the fractionation affects the salivary function?
So we do have two kinds of xerostomia, if you may call it. One is the acute xerostomia, and the other is the late or chronic xerostomia. So the chronic xerostomia would be a function of the fractionation that we use. And of course, we would see acute xerostomia also early on during therapy, and that is actually, this is not something that you would see with hypofractionation, but yes, with conventional and hyper or accelerated, we may see acute xerostomia. But chronic xerostomia will definitely become a problem with more hypofractionated schedules, and also with conventional fractionation if we use conventional techniques of radiotherapy.
Yes, that's right. Dr. Vipul, your comments on fractionation? Would you agree with ma'am?
Yeah, basically it depends on the how much dose you are using and what fractionation schedule. Dose per fraction is also important for the late toxicity of the radiation. So it depends on the dose and as well as the dose per fraction.
Yes. Can you go to the next slide, please? So the effect of radiation on salivary
One
gland.
minute, can I just say something, Sanjay?
Yes, ma'am.
About the factors affecting salivary gland function. One more very important thing that we need to remember is, besides just the radiotherapy and blaming the radiotherapy for all the xerostomia that we see, we need to keep in mind certain other issues like comorbidities, because you have a lot of patients who have diabetes. You
Yes.
have elderly patients who already have hypofunctioning salivary glands. And of course, very rarely you would come across the patient with connective tissue disorders whom you're going to be treating with radiotherapy. So this is something that we need to keep in mind. Of course, concomitant therapies, not so much. But then, if a patient is on some other therapies, also you may need to keep in mind. But then essentially diabetes, as well as the disorders, the connective tissue disorders, and very elderly patients also.
Where salivary flow is already affected. So that
Yes.
adds to our more radiation damage. That's right. So if you look at the factors affecting salivary gland function, so it is again what we discussed already, fractionation and already dose volume correlation. Next slide, please. So when we happen to see how does the changes happen, effect on salivary gland with function, I think we obviously see, as ma'am mentioned about the late effect and early effects, what we see change in the volume. Patient always in the OPD we see the consistency, how much change it becomes quite. Patient always complains it's a lot of secretions keep coming, change in consistency of that, and also the pH of the saliva changes. Next slide, please. So there's one study I found, basically it was on animal studies where the radiation damage was found, and they divided into phase 1 to phase 4, where they said the phase 1 was basically this depletion of water component effect on the SNR cells or the amylase secretion that was lasting for 0 to 10 days. And phase 2 had, in which the SNR suffer membranous degradation and lose the ability to secrete amylase. And phase 3 was again marks the phase of late toxicity, which is characterized by loss of functional SNR cells due to loss of progenitor stem cells. And the last one, which marks the regenerative phase, but the functional deterioration continues due to damage of ducts, nerves, and vessels. And it is believed that the salivary amylase become undetectable by the 10th day of the radiation due to SNR damage. You can go to the next slide. So, how do you look at the impact of QL on the patients? Sarbani ma'am, would you like to take up this?
So there are two ways of looking at it. Of course, you're asking related to patients.
Yes.
For patients, we would look at using the various questionnaires that you have, which are we are comfortable at TMH with using the URTC quality of life questionnaire, the head and neck QL QC 30 and 35, head neck 35, because we have it translated into the most commonly spoken languages. Besides that, you have the xerostomia questionnaire, you have the FACT HN, and you
Yes.
can also use the MADASI, which would be more relevant for xerostomia questions.
Okay. And Vipul, would you like to comment on this? Hello.
So basically, pardon. Hello.
Hello.
Am I audible?
Yes, sir. Go ahead, sir. Go ahead.
Yeah. basically is it affects the quality of life, causes basically dysostomia, and the assessment of the quality of life is both basically subjective. We are doing the subjective assessment by the quality of life questionnaire, in which most of the time patients is having a lot of basically the saliva's consistency is not good, so they are having poor quality in spite of sparing of the parotid gland also, because the serous function of the submandibular gland is not very good in initial after the initial time of the radiation, basically acute side effects.
So it, so we see that it's a survey of 65 patients. What I had found one trial was who had acute, I mean post radiation almost for 6 months. Majority of them had dry mouth, almost 90%. 43 had difficulty in chewing. I mean, these are the impact. I mean, what you see after patient gets xerostomia, and it related to difficulty in chewing, mastication, taste loss, altered speech. All these are related to the xerostomia, which impacts the quality of life of the patients undergoing treatment. And of course, pain was the most common, which interrupted daily activities. Most of the patients do complain to us about the pain during radiation also. And more than half of the patients had mood complaints, had interference by their physical condition on the social activities. Next slide, please. So again, I said earlier, the mastication issues. Most patients with xerostomia experience difficulty eating dry and hard food. And again, it leads to swallowing problems because generalized decrease in the mobility of pharyngeal structures. And after RT and prolonged pharyngeal transit with a delay and a delay of laryngeal closure. And there is always an elevation of the hyoid bone, which begins too late, and it was held in an elevated position for too long. That usually, affects the passing of the bolus down relative to the normal way how the bolus is arrived. Next slide, please. Now again, discussed also the difficulty with speech and the dental caries. And in the end, the combination of factors can result in decreased nutritional intake. Ultimately, this matters because patient goes on a poor intake and then there's a weight loss that interrupts majority of our patients undergoing treatment. Next slide, please. So moving on to the prevention of xerostomia. Dr. Vikram, would you like to take up how do you manage prevention of xerostomia? How do you tell the patient about this?
So the pharmacological interventions, I mean, there are not too many options for pharmacological interventions as far as prevention of xerostomia is concerned. One of the age-old approaches has been to use amifostine, and I think that has given some good results, and people continue to use that. But the only problem is, one must understand that there are several problems associated with amifostine, not the least being the incidence of hypertension and skin rash and Steven-Johnson syndrome and so on. And the other option is use of parasympathomimetic drugs like pilocarpine, because that will stimulate the secretion of saliva, and that can be used to prevent xerostomia as well. So these are the two pharmacological approaches that I can think of as far as prevention of xerostomia is concerned.
Ma'am, any experience about using amifostine in the clinic?
We did start using it when it came out, in a big way. But then the point is, we realized early on that it was going to be difficult for us, especially to use the IV formulation, because to act as a radioprotector, unlike the cytoprotector effect of amifostine, we had to do it every day. So that was going to be a problem. And then you have to administer it within you being able to deliver, like you have to administer amifostine, give the radiotherapy within 30 minutes,
Yes.
monitor the BP continuously. So then we actually restricted the use of amifostine as a radioprotector only in the hemibody situation and not for prevention of xerostomia. We stopped using, we didn't go on to using it in too many patients. But of course, with the trial by Brazil, which showed that even subcutaneous amifostine was as good as the IV without any difference in its efficacy, we still did not take amifostine and we did not use it in the clinic as much because by then I think IMRT was already in, and we started using IMRT more than any of the pharmacological agents for prevention or treatment of xerostomia.
Okay, thank you, ma'am. Dr. Vipul would like to add upon the radiation techniques on the prevention of xerostomia.
Yeah, definitely. The sparing of major salivary glands like parotid, or if it's possible to spare the submandibular gland, automatically it will increase the quality of life, because the sparing the consistency of the saliva would also be increased. And other things, if we are treating in the larynx, we can spare the oral cavity radiation, those minor salivary glands we can spare. So these all are the new techniques by which we can already give the good quality of life after the treatment, after the radiation, basically.
Next slide, please.
This is the slide.
Next slide, sir. Yes, radiation therapy techniques, I think, is already discussed. Advent of IMRT parotid sparing. Most importantly, if I don't mention the PARSPORT trial, I think I'm missing out on something, which was a landmark study about the conventional versus IMRT arms, where there was a severe reduction in the xerostomia in the IMRT arm. Next slide, please. So again, an important about submandibular sparing. I don't know how many would practice this in the clinic about the surgical transfer of submandibular gland to the submental space. I myself haven't experienced any of these patients having done this. If my panelists would like to throw some light on this, if they have seen some patients getting it done because of in order to prevent the xerostomia.
We did have a randomized study that actually did take place long back. Dr. Balawat was one of the chief investigators, and what they looked at was actually doing salivary gland transfer, surgical transposition in patients who were suitable, which meant that contralateral node negative, no chance of extension to the submandibular glands or the level 1B lymph nodes. They did try it. It was effective because we used to do a salivary scintigraphy to measure the effectivity. But of course, all this essentially enthusiasm came after Naresh Jha's a randomized trial by Rtog,
Yes.
which looked at the efficacy, and it did turn out to be effective. But then, with again the advent of IMRT, it went out of vogue because there was a lot of uncertainty as well as a lot of expertise also that was needed
Right.
to do it.
That's right. That's right. Next slide, please. So the recommendations is sparing at least one submandibular gland also appears to reduce xerostomia risk and increase stimulated and unstimulated salivary function. And when it can be deemed oncologically safe, submandibular gland sparing to modest of 35, less than 35 due to CNA effect might reduce xerostomia symptoms. Next slide, please. So if you move on to the treatment, again, I would like to ask Dr. Vikram, what are the pharmacological therapies you have, or how do you manage a patient with a xerostomia?
I think the treatment can be divided into two parts. One is replenishment of the saliva, which is at the core of xerostomia. And this can be done either through increasing the production of saliva. Once again, simple parasympathetic drugs like pilocarpine will be very useful here. Or you can use saliva substitutes, to kind of to mimic saliva-like function. So these are some of the things that we can do. And then there are several descendant effects of xerostomia. Like for example, we spoke about pain, we spoke about mood, and then we spoke about dental caries. We spoke about the risk of infection. So all these things have to be kind of handled, separately, and suitable supportive treatment has to be given for each of these conditions if they exist. So this is how probably one would pharmacologically treat the xerostomia.
Okay. Sarbani ma'am, when would you initiate the treatment? I mean, a patient do come in acute or chronic phase, or how do you distinguish and how do you decide the treatment?
Actually, if you look at literature, pilocarpine has been used for post-radiotherapy xerostomia by the FDA. The
Yes.
problem with using pilocarpine was that, its dosage, its side effects, and also there was very little literature as to the length of time for which pilocarpine should be continued. And often it was also noticed that if you stop the pilocarpine, very often you would get, the patients would go back to having xerostomia. So actually, I have used pilocarpine very sparingly, not too many patients that have used pilocarpine. Instead of that, what I usually do is actually advise patients to, like, I believe now that we can prevent. So that's why the emphasis on treatment has gone down. So we try to prevent and then prevent both the xerostomia as well as its consequences. So dental prophylaxis plays a big role. Also, that after completion of treatment, on treatment, of course, we keep on reiterating the same things and reinforcing it. And post treatment, again, we send the patients for regular dental prophylaxis. Keep on re-emphasizing the importance of keeping and maintaining a good oral hygiene. Tobacco abstinence is another thing that we emphasize to these patients. But besides that, we really do not use anything else that's very active, because the other thing that was proposed in some way was for mucositis and consequentially xerostomia was palifermin. Palifermin didn't come into India, and it was not because it was not available in India, and so we didn't ever. The other thing that has been tried in a randomized setting with good results is actually acupuncture. But then that is during therapy and post therapy also, because if you have a hypofunctioning gland, it may not be effective at all. So acupuncture is another thing which has been proven to be positive, and this is a randomized trial between China and the MD Anderson Center, and it is proven to be beneficial in actually keeping what you call preventing and treating xerostomia. So that's the other thing that can be kept in mind, though we really don't have any experience with acupuncture.
Okay. So again, it's basically palliative treatment for relief of symptoms when patient complains. Symptomatic treatment is increasing salivary flow, replacing last secretion, control of dental caries as discussed, infection treatment, and regular dental checkup, and basically a good oral hygiene, avoidance of smoking, and salivary substitutes which are used, and salivary stimulants like pilocarpine which we discussed. And again, ma'am emphasized on use of acupuncture, and again gene therapy which is still in coming up. So next slide, please. So in conclusion, I'd like to say xerostomia is almost ubiquitous long-term complication. Recently, significant progress has been made in the prevention of xerostomia. Like, IMRT has been used, surgical transfer of gland to the submental space. However, till date, it is impossible to successfully prevent radiation-induced xerostomia in all patients. I mean, whatever dose we give, we try to limit the parotid dose to 20-26 gray and ask them to have a proper oral hygiene. But still, few of our patients still have these head and neck cancer survivors continue to suffer from xerostomia, and maybe a further research on how further management, pharmacological methods, investigation is still warranted. Next slide, please. Now moving on to the next topic, that is mucositis. How do you define a mucositis? If you'll ask at any particular definition, if anyone would like to take this question. Dr. Vipul.
Yeah. Basically, it's inflammation of the mucosa that leads to ulceration, soreness, and erythema, everything. Basically, this is ulceration, inflammation of the mucosa.
How often do you see mucositis? How many of your patients experience mucositis?
Hello, am I audible?
Yes, audible, sir. How many?
Hello.
Hello.
Yeah.
You're audible, sir.
So it depends on the where the site of it. It totally depends on the site of the radiation, in which organ head and sites we are treating, and what are the doses. Basically, if we are treating oral cavity, definitely all patients will have the mucositis during the radiation. If we are treating the head, larynx or somewhere else, so some patients will have the mucositis in the oral cavity, but they will have the mucositis, pharyngitis, or mucositis in the other sites, other mucosa where we are treating. So it totally depends on the area where and the dose of the radiations.
Next slide, please. It is radiation-induced oral mucositis, one of the major radiation toxicities, and it was first termed in 1980 of side effect of radiotherapy. And mucositis is a normal tissue injury lasting 7 to 98 days, which starts after an acute inflammation of oral mucosa, like you have tongue, pharynx, or even oral mucosa after RT exposure. Next slide. Now look at the incidence. I think majority of our patients have it. Most of the patients, I mean, right from the conventional era, if you look at even when you're doing IMRT, almost 70 to 80% or almost 80 to 90% do have come up with a mucositis at some point of time, that is on grade 1 or grade 2. And moving on to the next slide, please. Moving on to the predictors and risk factors. Sarbani ma'am, would you like to take up this about the predictors and risk factors?
So we've talked about the volume that we're irrigating, the volume of tissue. So the volume of the salivary glands that are within our radiotherapy volumes would of course be one of the most important parameters. In addition, of course, the general health of the patient, the presence of comorbidities, whether we are going to be delivering any other concomitant therapies to this patient, especially with concomitant chemotherapy or 5-FU and cisplatinum do add to the concurrent mucositis. And so these are important parameters, but most importantly, as radiation oncologists, we'll have to look at the volume. And of course, because a lot of the definitive radiotherapy patients are also on in advanced stages are on concurrent chemotherapy, that's the other thing that we will have to look at. And most important, the other thing that we will have to look at is also about the mucosal, the thing what you call whether the patient is diabetic, because that's another
Yes.
important parameter that we see in day-to-day practice, which can interfere with the mucositis.
Yes, that's right. Next slide, please. So if you look at the predictors and risk factors, that is a type of treatment. As ma'am rightly said, if you're giving only radiation or in locally advanced cases where you give concomitant CTRT, cumulative radiation dose and the volume which we are treating, that is the most important factor. And again, patient-related factor like smoking and body mass index. And it is said that patient who received CCRT had a higher cumulative radiation dose were smokers who have a lower BMI, have a higher risk of developing mucositis. And radiation related symptoms were again predicted by type of treatment as done cumulative radiation dose and the smoking. Next slide, please.
One is also a very important factor is the nutrition. If
Yes,
patient
that's
is
right.
not properly is not taking proper nutrition, then automatically they will have the more side effects.
Mucositis. Next slide, please. And again, young age, it is said that female gender do have higher preponderance of that, and poor oral hygiene and poor oral health, decreased salivary secretion, low BMI, and poor renal function. Comorbid conditions are also one of the responsible factors for it. And history of radiation-induced mucositis are risk factors predicting the development of ROM in head and neck cancer patients. Next slide. So, I mean, why are we discussing about mucositis? Now, I'd like to highlight what is the global burden, what is the problem we have. So, radiation-induced mucositis injury challenges radiation oncologists from many aspects. The radiation dose limitations we have, changes in dose fractionation, protocol, dramatic negative effects on patients' quality of life. Now, if you look at patients who have mucositis, most of them require, parenteral nutrition sometimes when it is grade 3 or grade 4, to stop our treatment, give adequate analgesia, give antibiotics. And there's one study where they've said almost 6 locally advanced cases where they're treated. I'm talking only of locally advanced, where 50 to 60% patient required hospitalization, and almost 3 to 4 grade 3 and 4 oral mucositis were found. And again, the dependence on tube, when there is mucositis, obviously the feeding is compromised, then the feeding tube insertion is done in majority of the patients. And reduction or cessation of cancer treatments occurs in almost 30 to 35% patients due to the developed dose limiting toxicities. Next slide. So how do you grade mucositis? Now, what I follow in my OPD is probably the Rtog grading, which is probably the most common one. Do you agree? The panelist, Sarbani ma'am, do you agree with the Rtog scaling? What you do?
Yeah, so we commonly use the RTOG or the CTCAE version 5.
Okay, Dr. Vipul.
We are using RTOG basically.
Okay. Next slide, please. So this is how the Rtog or WHO grading for oral toxicity. Grade 1 would be soreness, erythema. Grade 2 will be ulcers. Patient can swallow solid food. And again, grade 3 will be ulcers with extensive erythema. Patients cannot swallow solid food. This is which is a major, mucositis, that is grade 3 and grade 4, which interrupts majority of treatment when there is compromise on nutrition of majority of the patients. Next slide. Now, if you look at the pathobiology of the mucositis, it is basically divided into 4 phases. That is initial phase, inflammatory, epithelial phase, ulcerative phase, and the healing phase. Next slide. Now, this is a good diagrammatic picture where the pathobiology is explained, where the normal tissue with the insult of radiation and chemotherapy, there are reactive oxygen species, ROS, which is released from the epithelial cells, endothelial cells. They cause lethal and non-lethal DNA damage. And then there's a primary damage and signal amplification, which activates NFKB by ROS and activates tumor necrosis factors that in turn leads to DNA damage and injury and cell death. And then there is an ulcerative phase. There is cell death threshold exceeded, resulting in the ulcer and disrupted basal membranes. And there is ulcer pseudomembranes, stimulated submucosal macrophages are formed. And then finally, the healing phase where signal from extracellular matrix stimulates basal cells to migrate, proliferate, and differentiate. Next slide, please. This is a diagrammatic picture where nicely it's explained how the different phases, that is initial phase, primary damage phase, signal amplification with activation of tumor necrosis factors, and then finally there is ulcerative phase in this. Next slide, please. So how do you prevent this thing? Dr. Vikram, would you like to take up on this about the prevention of mucositis?
Yeah, so I mean, prevention, I think there are not too many options available. I mean, other than good oral hygiene. So that should be encouraged in all the patients. And apart from that, some of the dietary habit, I mean, in the sense, some other management which are slightly innocuous are like ice crushers and, encouraging people to eat more fruits and purees and so on and so forth. So those may be useful. But in addition, I would like to bring the attention of the audience and the panel to some of the interesting studies that is ongoing in Tata Hospital. I mean, not necessarily for the prevention of radiation mucositis, but there were some interesting studies that has happened for the prevention of high-dose chemotherapy-induced mucositis in the setting of bone marrow transplantation. And if you look at the previous slide where the moderator showed the pathogenesis of oral mucositis following radiation injury, where it includes stimulation of NF-kappa B and subsequently release of certain cytokines like such as IL-6, TNF-alpha, and interleukin-1 beta, and so on. So there are several drugs which can actually bring down these cytokine levels, and one of the classic examples is curcumin. And when we did this study in bone marrow transplantation, following high-dose melphalan treatment, we could demonstrate that, I have the figures here, that, curcumin could actually reduce the mucositis by almost 20%, following high-dose chemotherapy. And it also reduced the use of need for total parenteral nutrition by almost 50%. So, I mean, since, these things are going to, the pathology is more or less similar for radiation mucositis as well. I'm of the firm belief that, probably some of these agents like curcumin, resveratrol, and more recently we're working on an agent called chlorophyllin. So all these things may be, useful for radiation mucositis as well. But of course, they have to be kind of evaluated prospectively in a clinical trial setting. But till then, I don't think we have too many options for prevention except for, good oral hygiene and also,
Dietary recommendations.
Dietary recommendations. Yes. Thank you.
Next slide, please. So good ways to take good oral care, probably I would suggest rinsing with non-irritating solution, daily ultra-soft brushing with a fluoride toothpaste, scaling and cleaning, very soft diet. I mean, this is a dietary recommendation. Typically, assessed diet, I mean, things to avoid is basically rough food, potato chips, basically which are more spices, salt, acidic fruits, and habits to avoid, of course, smoking and alcohol. Next slide, please. Now, how do you look at the treatment of ROM? I mean, I'm sure this has a lot of answers because there's no single agent. Now, it's out of our experience. Dr. Vipul, would you like to take up this?
So basically, the radiation-induced mucositis should not hold the radiation. So our concern to give the proper nutrition to the patient. First concern of this mucositis. So many times we are placing the nasogastric feeding tube, because the nutrition, only the way of giving the nutrition or pack tube is not very easy. Patient is not ready for that. So most of the time we are placing the fracas tube for the nutrition purpose. And definitely for the oral hygiene, we are giving basically benzodiazepine gargles, which are anti-inflammatory as well as the antiseptic. And for pain, we are giving the xylocaine viscous just to he can switch and spit that. And other, if fungal infection is there, definitely we have to give the lozenges, chloral or something antifungal. So main thing is to give the proper oral hygiene, give the a lot of medicines to give the gargle and all that, and nasogastric trachea tube for the nutrition purpose.
Okay. How many of your patients, when you're treating locally advanced, suppose you're treating pharynx or hypopharynx, would you advise upfront feeding tube or nasogastric tube?
So upfront patient is not willing because they are saying that we are able to take the whenever we need, then we'll ask for that. So we are monitoring the weight, and whenever we are finding there is a loss of weight or if proper is nutrition, he is not taking proper nutrition, then we are placing it mainly after the 15 fraction or 10 fraction. Totally depends on the patient's general status as well as the if patient is having receiving the concurrent chemo, so definitely he will have the earlier grade 3, grade 4 mucositis compared to the those patients who are not receiving.
Sarbani ma'am, would you take on feeding tube?
Okay, so our practice in the OPD is actually today to do reactive tube feeding. We do not prophylactically place tubes because we've had a long experience with this, and we realized that our patients who were undergoing reactive tube feeding, that is placing it when either there were triggers for placing in a tube or for enteral nutrition other than oral nutrition. So for that, we realized that our patients did much better when they had the tube feed placed. So, and now we are actually doing a randomized trial to look at reactive versus prophylactic tube feeding. And the reason for this is essentially because in our population of patients, what also happens is, and of course, even in the Western population where they tend to use prophylactic tube feeding as the first step, there is, of course, a thing that most of the literature from the West comes on the PEG tube rather than the nasogastric tube. But for our patients, managing the PEG tube is actually an added burden. Maintaining the peg site, its hygiene, dressings, the leakage, peri-peg, all those things are very important considerations. So we do tube feeding with the NG tube as and when necessary, not prophylactically. And we look at the patient's weight, or if a patient has electrolyte imbalance, is not taking adequately. So there is a weekly visit with the nutrition clinic people also when the patient is essentially on definitive radiotherapy. So that's our approach to the tube feeding part of it.
Do you see any difference? Do you see any difference in SIB and sequential way of treating the patients? Like some follow 17-35, some follow 66-30. Do you see any amount of mucositis being more or tube dependency being more on both the treatment model? I mean the protocols.
I must confess here that we always do SIB. We do not do sequential IMRT. So it's difficult for me to comment on that aspect.
Okay, Dr. Vipul.
Yeah, actually it's very difficult to because there is no such trial or something which is compared from the 70-35 or 36-30. So basically, it totally depends on the volume of the treat area which we are treating. If your 0.2 gray is the larger volume, definitely patient will have the more toxicity, basically the later toxicity. So I can't say anything, but most of the patients are having because if we are treating oral cavity, then patient definitely patient will have more toxicity.
That's right. Next slide, please. So again, agents investigated or applied what we use in most of our clinics is again well known to us: L-glutamine, local anesthetics, benzocaine, and the magic mouthwash that is lidocaine, diphenhydramine or magnesium aluminum hydroxide, and morphine mouthwashes. And again, vitamin A, vitamin E supplements we give. Next slide, please. And again, the benzodiazepine hydrochloride, which is non-steroidal, antimicrobial, anti-inflammatory anesthetic agent, scavenges the ROS. And again, the povidone iodine, which is used, which is antiviral, antibacterial, and few systemic agents like N-acetylcysteine, COX-2, no hard evidence on it, and use of systemic steroids. And as mentioned, antibiotic lozenges with polymyxin A and tobramycin are protected against severe mucositis. Next slide. So in conclusion, I would like to say it's a self-limiting toxicity, dose-limiting toxicity in most cases of head and neck cancers. However, in moderately to severely sick patients, it could be lethal injury. And currently, there are numerous prevention and treatment strategies, but no single agent or management regimen that has been agreed to significantly improve mucositis to a clinically relevant and satisfactory standard. Next slide. So at last, I would like to say we look at the quality of life of the patient. Whatever we do, we are looking at controlling the disease, but not giving a complication which really hampers the quality of life of the patient. So that's all we have for today. Thank you, panelists, and thank you, organizers, for giving us this opportunity.
Thank you, everyone.
Thank you very much. Thank you.
Thank you, Sanjay. Very good. I enjoyed the panel.
Thank you, ma'am.
Good,
Thank you.
right.